Now coming to subcostal. Here you place the probe in the subcostal part and you cross the liver to examine the 4 chambers of the heart. Here you have the right ventricle, right atrium, left atrium and the left ventricle. Here you can see this is the right ventricle, the tricuspid valve, right atrium, and here you have the left ventricle and the left atrium. In this view, you can even look at the interatrial septum and the interventricular septum along with the 4 chambers of the heart. Next comes the subcostal view for the IVC diameter. Assessing the volume preload of the heart, this view is very important. All you do is measure the IVC diameter and the collapsibility index of the inferior vena cava. Now coming to the types of aortic regurgitation, there are 3 main types of aortic regurgitation and 4th type is also there, and these types are based on mechanism of AR, how the AR happen. In type 1, there is a functional dilatation of this aortic root so that blood from the aorta comes back into the left ventricle, or you can have a cusp perforation so that the blood from the aorta comes back into the left ventricle. This is type 1. Coming to type 2, here you can see the cusp is totally prolapsed, so they don't approximate properly. Because it is not approximating properly, the blood from the aorta goes back into the left ventricle, or it can be a partial cusp prolapse. This is type 2. Coming to type 3, here the cusp is retracted and shortened. Here there is going to be slight mitral valve prolapse, but the coaptation of both the leaflets will be normal. They will be maybe mild valve thickening and the leaflet motion may be restricted. This is grade A, but your valve hemodynamics is there is no MR jet or a small jet which occupies less than 20% of left atrium, small vena contracta which is less than 0.3 centimeter, and there is no hemodynamic consequences and no symptom in at risk of MR. Coming to grade B, here it is called the progressive mitral regurgitation. Here there is severe prolapse with normal coaptation or rheumatic changes with leaflet restriction and loss of central coaptation, or prior infective endocarditis will be there. Coming to right ventricle, the right ventricle is usually normal in the absence of pulmonary hypertension. But if pulmonary hypertension sets in, there is going to be oxygen supply demand imbalance as well as a secondary abnormality of left ventricle also. Here normally the right ventricle is concentric shape and the left ventricle is circular, and the cross-sectional area of the right ventricle is 1/3 of the left ventricle. But what happens with severe PAH? Here now the right ventricle assumes a semi-spherical shape. That means it occupies the larger cross-sectional area and your oxygen demand supply will be altered. Now you can see the septum being pushed towards the left ventricle and the left ventricle function is also compromised. Now coming to staging of aortic stenosis. Stage 0, where there is no aortic stenosis, your left ventricle and your aortic valve and the left ventricle is absolutely normal. Here there might be certain factors which will increase your risk for aortic stenosis like hypercalcemia. Now coming to stage 1. Here this is the stage 1. There is mild aortic stenosis. If you look at the echocardiogram, there might be an increased left ventricle mass. The left ventricle mass can be greater than 115 gram per meter square in male or greater than 95 gram per meter squared in female. There might be slight LV damage and your ejection fraction is less than 50%. This is stage 1.